Okay, good morning, good afternoon, good evening po sa lahat. Saan man pong panig kayo naroon sa mundo. Welcome po sa ating 174th episode, 174 episode of Stop Movie Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community. And to all those who have just discovered us today, welcome po. At sana po marami po kayong matutunan sa isang topic po na hindi po natin laging napag-uusapan. And I am talking about palliative and hospice care. Dito po sa mundo natin where healthcare often revolves around curing ailments, hindi po natin masyado pag-uusapan yung paano po ba yung compassionate care, paano po ito maging within the context of ng Pilipino. So palliative and hospice care often regarded as the epitome of compassion in healthcare, focusing on enhancing the quality of life for individuals facing life-limiting illnesses. In the Philippine context, where familial bonds sa ating mga malapit sa buhay, kapamilya, and cultural values are paramount, yung significance po ng care na ito ay very, very emphasized and very pronounced. So for today po, ang ating pong distinguished panel of speakers who will be bringing their wealth of experience in navigating the complexities of palliative and hospice care within the Philippine context. Yun po ang pag-uusapan po natin today. Exploring po, touching on cultural sensitivities, ethical considerations, and practical approaches po in order for us to better understand ano po ba yung standard of care and how to elevate it dito po sa, let's say, final chapters ng kanilang mga buhay. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And also looking forward po every Friday because I get to share hosting duties with our adjunct research faculty at the National Telehealth Center. Also international renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie.
Hi, Raymond. Good afternoon, and good afternoon to everyone who's with us here on the live Zoom broadcast webinar, and to all of you who are watching on the playback. I'd also like to greet those who are live streaming on TVUP YouTube channel, the UP System Facebook page, TVUP Facebook page, Stop COVID Deaths Facebook page, and of course, all who are watching from TVUP Signal TV channel 101. And as Raymond said, it's a very exciting topic. I think we have to think about the fact that we are all just, mere mortals. No? And we have brought some of the best speakers we could possibly have to share with you the latest on hospice palliative care. So we have our main presenter, Dr. Andrew E. Ang, who is the Chief of the Division of Supportive Hospice and Palliative Medicine from the Department of Family and Community Medicine at the UP Philippine General Hospital, while our reactor is Dr. Karin V. Estepa Garcia, who is the immediate past president of the Philippine Society of Hospice and Palliative Medicine and also current chair of the PGH Department of Family and Community Medicine. Synthesis and closing remarks will be delivered by Dr. Agnes Soriano Estrella, who is Chief of the Division of Trophoblastic Diseases at the Department of Obstetrics and Gynecology at UP PGH. And we're still using the Stop the COVID Deaths title, but I think maybe next year we might be moving towards another kind of a title, same program, maybe a little bit more expanded. But currently we are covering so many different topics, and that's why today we will be talking about hospice care, palliative care, and supportive care for all kinds of patients who have both chronic and terminal illness. Anyway, since we know that you're always looking forward to the news from here and abroad, it's our pleasure to bring you the news update.
Thank you so much, Dr. Susie. Pag-usapan po natin probably a continuation of what we have discussed previously on this respiratory infection clusters doon po sa northern China. Ayon po dito sa balita, respiratory infection clusters in China not caused by novel virus according po sa kanilang health ministry, with data being supplied to the World Health Organization and China saying that the flu and other known pathogens are the culprits. So recent clusters of respiratory infections are caused by an overlap of common viruses such as influenza, rhinoviruses, RSV or respiratory syncytial virus, and adenovirus, as well as bacteria such as Mycoplasma pneumoniae, which is the common culprit for respiratory tract infections. Ito po ay ayon sa China's National Health Commission spokesperson. The ministry called on local authorities to open more fever clinics and promote vaccinations among children and elderly people as China grapples with a wave of respiratory illnesses in its first full winter since the removal of COVID-19 restrictions. Earlier this week, yung World Health Organization formally requested China to provide information about the potentially worrying rise in respiratory illnesses and clusters of pneumonia sa mga bata po in children, as mentioned by several media reports and a global infectious disease monitoring service. The emergence of new flu strains or other viruses capable of triggering pandemics typically starts with undiagnosed clusters of respiratory illness. Kaya po very worry, very cautious, and very much attuned and monitoring closely po ang WHO sa mga ganito. Both SARS and COVID-19, nung nag-umpisa po sila, they were first reported as unusual types of pneumonia, katulad po nito. What about you, Dr. Susie? What's your news?
Okay, so Raymond, between the 24th and 25th of November, the Ministry of Health of Cambodia notified WHO of 2 confirmed cases of human infection of influenza A, H5N1, from the same village in Kampot province. Both cases were female, one in the age group of 20 to 25 years old, and the other one less than 5 years old. The first reported case visited a public hospital for 4 days after having symptoms of fever, shortness of breath, and cough. Samples were collected, which tested positive for H5N1, and the patient actually died in the hospital. The second reported case was detected during enhanced surveillance by the public health authorities in response to the confirmed first case. The case had fever, cough, and rash, is currently being treated in a hospital. Epidemiologic investigation shows both cases had exposure to backyard birds, which were reported to be sick, with some having died. Over the prior month, influenza A or H5N1 infection, as it has been reported, we know can cause severe disease and has a high mortality rate and is notifiable under the international health regulations. So typically, this is a disease that is transmitted between birds. But as we're seeing in Cambodia, there seems to be human transmission. And again, this is one of the diseases that is currently being monitored under international health regulations. And that's our news for today. We'll be back next week with more for you on the news update. Okay, and we are back. So we've got a very interesting topic, Raymond. I think
That's true.
I'm looking forward to hearing and learning more about it. I don't know kung tumatanda lang ako, Raymond, pero parang more and more people I know have chronic illness or cancer, and so it's very relevant even for our audience to hear more about what do you do when you can't do much more than
That's true.
provide support for patients. So I think we will also hear a little bit from our persons on the street. So kindly introduce this, Raymond.
Thank you, Dr. Susie. For those who are joining us and try to understand po ano po yung person on the street video, it's sort of setting the baseline kung ano po yung alam po ng persons on the street. Hindi nyo po naitatanong, marami po yung nagka-clamor for this type of topic po just because they are trying to look kung meron daw po parang hospice care dito sa Pilipinas. So very, very timely po ito. Ang ating mga katanungan sa ating mga in-interview for the person on the street video are as follows. May mga kakilala ba kayo nag-aalaga ng mga kapamilya o kamag-anak sa bahay? Narinig nyo na ba ang mga katagang hospice care, palliative care, supportive care? Sino-sino sa tingin ninyo? Ang mga pasyenteng makikinabang kapag makatanggap ng hospice or palliative care? At sa tingin ba ninyo ay tama lang na alagaan ang mga ganoong pasyente sa loob ng bahay? Please watch this.
Ako po, nag-aalaga ako ng tatay ko, bedridden po siya. Nagkaroon po siya ng tuberculosis.
Meron akong kakilala, mga kamag-anak ko.
Yes, meron ako mga kakilalang kamag-anak o mga kaibigan na nag-aalaga ng mga pasyente sa bahay nila.
Hindi ko pa naririnig kung ano yung hospice care tsaka palliative care.
Oo, narinig ko. Mga taong may konting oras na lang sa buhay nila. Hindi mga sakit, hindi malalang sakit.
Narinig ko na siya na medical term, pero ang pagkakaintindi ko dito, ang hospice care or palliative care ay more on extended hospital assistant sa mga pasyente. So, siya yung mga inaalagaan sa loob ng bahay.
Tingin ko yung makaka-benefit talaga, makakakinabang talaga nung ganong klase. Siyempre kami na hindi naman din ganun karami yung sinusweldo, lalo na kung libre siya. Especially mga taong wala ding mag-aalaga sa kanila kasi thankfully kasi magkakapatid kami, so pwede na kami nagpapalitan sa papa ko. Pero paano kaya yung mga taong wala talaga mag-aalaga sa kanila, sila lang mag-isa, o yung mga anak nila, anak niya bata pa, na hindi pa siya kayang alagaan talaga.
O, ang mga taong nakikinabang o nakaka-receive ng ganitong klaseng pag-aalaga ay yung may mga malulubhang sakit na more on lifetime na siya, like cancer or yung mga yung kailangan talaga ng extensive monitoring.
Siyempre yung mga taong may mga taning na lang yung mga na sa sandaling buhay nila, mas makakakinabang sila sa ganung klase ito.
Yes, sa tingin ko, magandang at epektibong paraan ito para maalagaan yung mga pasyente kasi mas mura kasi sa loob ka na lang ng bahay. And kasama mo yung mga pamilya mo, so mas maraming nakasubaybay sa health mo.
Tingin ko hindi siya dapat, pero kagaya ko na napupuwersa kami kasi hindi naman sapat yung kinikita namin para magkaroon ng extra pang bayad kung lalagyan namin sa ospital yung papa ko, kasi syempre may mga bayad yan sa treatment. Sa bahay walang bayad. Tapos, ang gagastusin ko na lang yung mga kailangan gamot niya o ang kailangan niyang kainin. So, nakakamenos kami sa gastos ko sa bahay. Hindi yun ideal para sa amin, pero ayun na kasi yung pinakamagandang option na meron kami.
Very strong sila kasi kahit na sobrang mahirap sa kalooban, na nakikitang nahihirapan na yung kapamilya nila, mas pinipili nila, siyempre na sa sandaling oras, kasama yung pamilya.
Minsan nakaka-discourage kasi hindi namin nakikita yung hope na babalik siya sa dati niyang sigla. Kasi ilang taon na rin nung nangyari sa kanya, tapos ngayon ganun pa rin yung sitwasyon niya. Alam namin na nandun pa rin yung presence niya, tsaka it's mas okay na rin yun kaysa mawala siya altogether.
Oh, I think naputol, Raymond, ano?
No, sa dulo po na natuloy naman po. But I think it's more they're trying to better understand their situations from a financial perspective, Dr. Susie.
Oo,
More
talaga.
so.
Kasi it is so terribly, terribly expensive to have a patient in the hospital for a long period of time. And then it's also anyway, we're gonna hear from our experts, no? It's also the quality of life of the person who's at home. Siyempre, masarap yung nasa bahay, di ba? So I think I'm very excited to hear what our experts are going to say. But I think you have some housekeeping muna, Raymond.
Yes, thank you, Dr. Susie. For everyone po who's asking, 50 if you have watched at least 50% of the webinar duration, then you will be eligible to receive a certificate of attendance po. We have sent out for all 173 webinars ito po mga certificates of attendance. Please also note that you need to register po for each of those shortened URLs. That will be bit.ly/stop COVID deaths webinar, and then if it's webinar 175 for next week, it will be 175 po. Hindi po siya one time lang po na registration and then it's for everything po. So you need to register for each of the episodes po or each of the webinars each and every week. And if you feel you should have received a certificate but did not, please let us know by emailing us at stopcovidets@up.edu.ph. For our webinar today, we'll be having a standard panel discussion format. And after our speakers have presented, that will be followed by a Q&A session. But before we delve into the webinar proper, we'll have a short segment po, which is our fun quiz segment, which will be prefaced po by a very quick and cute intro video.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com or go to www.menti.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Okay.
Okay.
So, that
Thank you
is...
so much.
Thank you.
Hindi na
Thank
siya
you,
hindi na siya mermaid, Dr.
Hindi
Susie.
na siya mermaid, ano. Anyway, so I think, yeah, Raymond, let's go straight to the, to the fun quiz.
Fun quiz. Okay, can we have the Zoom also? So for those who are outside of the Zoom po, no, I'm not sure why we mentioned Menti, but we are doing Slido. That we used to do Menti, but we're now doing Slido.com. So you just open up your browsers, you enter in the address bar, you type it in Slido.com, and then when you're prompted, you enter the code 6510096. That's 6510096 for you to be able to participate in our fun quiz segment. Nakikita nyo po dito, 20 katanungan, especially for those who are in the Zoom po, no?
Uy, teka muna, Raymond. Ang
Ay, hindi, it's a
naka-on
panel
sa...
discussion format. Sorry, that should be...
Oo, dapat yung fun quiz.
Yeah. Can we launch the
Nasa
fun
poll
quiz
side.
dito po sa Zoom? Kasi na-launch po yung panel discussion form. Thank you. Fun quiz number 174 po dapat. This should not be the one being...
Yan.
Yan,
Okay,
there
you
we
got
go.
it. You got it.
Okay,
You got
so
it.
we have two questions here. First question, what types of patients may receive hospice or palliative care? Is it A, cancer patients, B, terminally ill patients, C, end-stage renal disease patients, D, stroke patients, and E, all of the above? So, obviously, we'd like to greet those ating mga masugid na taga-subaybay joining us from the DSWD, the Department of Social Welfare and Development Haven for the Elderly in Tanay Rizal, Region 2. Trauma and Medical Center in Bayumbong, Nueva Vizcaya, Corazon Locsin, Monte Libano, Memorial Regional Hospital in Bacolod, Negros Occidental, Abuyog District Hospital in Abuyog, Leyte, Zamboanga del Sur Medical Center in Pagadian City, Zamboanga del Sur, and Socsargen General Hospital in Surala, South Cotabato. We'd like to greet those dito po na sa naglagay sa ating chat from the University of Rizal System Health Services Unit. Maraming salamat po. From Ear, Nose, Throat, Head and Neck Surgery Center of the University of Santo Tomas Hospital. Thank you so much. University of Santo Tomas, thank you. RPHS Annex 1 from Antipolo, I believe. Maraming salamat po. Those joining us from Bataan, from Los Baños, Laguna, from Loma de Gato in Marilao, Bulacan, from Diliman, Quezon City, obviously from the Philippine General Hospital. Thank you so much. From Cavite, maraming salamat po. Meron din po tayong we have those from outside of the Philippines whom we'll be greeting later on afterwards. For question number 2 reads, what types of treatment can palliative or hospice care patients receive? Is it A, pain and other symptom management, B, advanced care planning, kung ano po yung gusto po ninyong mangyari towards the end of your life, letter C, bereavement care, especially for the family members po na may iwan, and letter D, all of the above. Okay, so we'd like to greet those who are joining us outside the Philippines, from our colleagues from Algeria. Thank you so much for joining us from Hail in Kingdom of Saudi Arabia, from New Sinai School and Colleges. Thank you so much. Los Angeles, California, United States of America, University of the Philippines, Nursing Alumni Association International Incorporated in Edison, New Jersey in USA, Bismarck, North Dakota in USA, Chonin Hospital in Taipei City in Taiwan, Taif, Saudi Arabia, Canadian Medical Center in Dammam, Saudi Arabia, as mentioned, University Hill in Hail, Saudi Arabia, from Jakarta, Indonesia, welcome, and Penang, Malaysia, as well as Lunichi Ali University of Blida 2 in Blida, Algeria. Okay, so maybe towards the end of our webinar proper, when they're doing the final messages just before that, we'll be asking our experts po what will be the correct answers for these two questions that we have as part of our fun quiz. And without further ado, we'll go straight into our webinar proper. Dr. Susie will introduce our very first speaker.
Yeah, I know you're all excited to hear our first speaker, so let me introduce him. He is the chief of the Division of Supportive, Hospice, and Palliative Medicine from the Department of Family and Community Medicine at the UPPGH Medical Center. Please welcome Dr. Andrew E. Ang. Dr. Ang, welcome.
Good afternoon po. Thank you, Doc Susie and Doc Raymond.
Go ahead, sir.
So, mag-share na po ako ng screen.
Yes, please. Go ahead.
Yes, please. Thank you po.
Yeah. Malinaw po ba yung screen?
Yes, it looks good. Thank you,
Yes.
Dr. Andrew. Go ahead, sir.
Alright. So, magandang hapon po sa mga nakikinig, sa mga nandito sa Pilipinas. I understand we're also international, so good morning, good afternoon, and good evening to everyone else listening and watching. So thank you, TVUP, for inviting us over to talk about something we're very passionate about, and that is palliative care, palliative medicine, hospice care, and home care. What was virtually an unknown specialty a few years back has gained so much ground in the last 5 years that every hospital wants a hospice program. The only thing I think that is keeping us from extending the care is the lack of specialists. Although our society is giving everything possible to make it possible para magkaroon na po ng specialists sa mga ibang hospitals. The title of today's presentation is Malubhang Sakit, Pwede bang alagaan sa bahay? Providing palliative care at home. So to address this question, let me show you the outline of today's talk. So I'm going to start with giving a review of what palliative care, what hospice care, or what home care is. I'm going to talk about the scope of its care and its services. I'm going to give an overview of what hospice home care is. Touch a little bit about bereavement care. Ito po yung mga binanggit kanina dun sa video clips na shino kanina before we start. So I'm going to also share a few cases of actual patients being taken care of at home. So just to give a little context. And lastly, we're going to give you a hotline or a number or a Facebook page that you can call or reach out. So if you have somebody who you know that you think would benefit from palliative care, palliative medicine, or home care, meron po kayong matatawagan. So to start the formal ball rolling, let me lift a definition of palliative medicine from the Palliative Medicine and Hospice Care Primer 2020. So palliative medicine is a specialized medical care available to patients, whether child or an adult, and their families dealing with serious diseases. It is a type of holistic care that focuses on the relief of symptoms, pains, and stresses. Can be offered in the hospital, at home, in dedicated centers, hospices, or centers for the elderly. Along with the goal of improving the quality of life by helping with the symptoms, palliative medicine can help patients and their families understand their choices for medical treatment in their own terms. Hospice care, on the other hand, is all of the above, except that the intent of treatment is no longer curative, but more comfort care, and usually the patients have less than 6 months to live. So let me go to the other definition, this one coming from the World Health Organization. So sabi ni WHO, ang palliative care is an approach that improves the quality of life patients, again, adults and children, and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through early identification and correct assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So, parang ang daming words, pero kung hihimayin po natin, there are actually 3 bullets or keywords that I think we should just remember. So, unang-una, ang mantra or ang goal is the improvement of the quality of life of patients and families. Pero paano may improve yung quality of life? So evidence tells us that most patients with debilitating illness, they suffer from pain and other symptoms. So para mag-improve yung nararamdaman nila, kailangan maayos mo yung nararamdaman nila. So kung pain yung nararamdaman nila, pag na-alleviate mo yon or napalit mo or na-control mo yon, may improve yung quality of life. Parehas ng pasyente at saka families. So what is also common in palliative care is that there should be a life-threatening illness. Kasi kung diabetes lang siya na hindi naman po end stage or hindi naman grabe, baka hindi po siya pwede for palliative. Doon muna siya sa endocrinologist. So similarities and differences, just to hit the nail right on the head, ang palliative care po is, again, a holistic care given to patients and families, focusing on relief of symptoms and stresses. It can be offered in the hospital, the home, the dedicated facility. Mantra is the best quality of life possible. Ang kailangan lang pong ma-delineate sa palliative care, ito po, pwedeng ibigay alongside curative measures. So even if the patient is just stage 1 cancer, she can be referred or he can be referred to palliative care. So ang tanong, ano gagawin ng palliative care specialist? Hindi pa naman mamamatay yung pasyente. So ang pwede pong gawin ng palliative care specialist is, again, alleviate the symptom. Kung meron man pong hindi maayos, yung nag-refer na doktor, dun sa mga symptoms na meron, dun papasok si palliative care. Kung kaya naman niya yung symptoms, then din maigi, pero pwede pa rin pong pumasok si palliative care to address the psychosocial issues or the other issues. So dito po papasok yung better illness understanding, yung disclosure, if there are other concerns of the patient with regards to his or her illness, dun po tayo papasok. Sometimes, yung psychosocial issues, yung pong relationship with the husband, yung relationship with the family, minsan na may miss out po yun ng primary service. So doon po tayo pumapasok. So hospice care, on the other hand, is the same again as palliative care, except that it's given when treatment is no longer desired or beneficial to the patient. So sino po ba nagsasabi na hindi na gagaling yung pasyente? So ang rule of thumb, at least 2 or 3 doktor ang magsasabi na mukhang hindi na po kayang gamutin ng usual treatment yung sakit ninyo. Of course, you have to say it in a very, very gentle manner and there's a way for us to do that. Pero kung just for the purposes of conversation, pag may nagsabi na pong doktor, 1 or 2, 2 or 3 na talagang hindi na kayang gamutin ng usual, mukhang pang-hospice na po yung pasyente. Tapos ang goal is no longer to cure, but to continue care and provide comfort. So whatever it is that's making it bad for the patient, whether it be a physical symptom, an emotional symptom, or spiritual symptoms. Ang joke po namin palagi, baka yung husband yung nagkakos ng pain, so i-remove natin yung husband. So, ang isa pa pong clincher, lalo na sa US, the patient has to have a life prognosis of less than 6 months. Ito hindi masyado sa atin ginagamit. Pero sa States po kasi, ang hospice care, mas malaki po yung insurance benefit compared sa palliative care. So the bigger picture is palliative care, under palliative care is hospice care. Pero mas malaki ang insurance coverage ng hospice care. So kaya pag less than 6 months to live, nire-refer na po nila sa hospice. Of course, kailangan may consent ng pasyente at saka ng family. So most of the time, hospice is done at home, which we are going to focus later on. But it can be given also in the hospital or in a dedicated hospice facility. There is one patient now in the hospital. Hindi po siya cancer patient. Ano po siya? Chronic kidney disease. So dapat po mag-dialysis na siya. Pero very, very loud or very, very decisive po yung pasyente na hindi siya magda-dialysis. Ayaw niyang mag-dialysis. Ayaw niyang malagyan ng tubo sa leeg. Ayaw niyang malagyan ng AV fistula. So sabi niya, nabasa ko yung hospice, pwede nila akong gamutin. Kung ano man yung lumabas na symptoms, gagamutin na lang nila ako. Pero wag niyo po akong dadialysis. So, yun po yung isang example na kahit hindi po cancer patient, pwede po natin siyang i-include sa hospice care. At pwede din pong hindi sa bahay. Pwede din sa ospital. Kasi yung kidney specialist, pinapauwi na po siya kasi hindi na po siya pwedeng mag-dialysis. Kaso, baliktad po ito dito sa topic natin, ayaw niya sa bahay kasi parang ang feeling niya, mas comfortable siya sa ospital. So, ang importante po dito, yung care niya nanggagaling dun sa sariling preference ng pasyente. So, for whom is palliative care? So, sinabi natin kanina, life-threatening illnesses. But to be specific, ito po yung mga pasyente na karaniwan na sinaservisyohan ng palliative and hospice care. So, sikat po yung cancer. Sinabi ko kanina, pwedeng stage 1, pwedeng stage 2, 3, pero mas common po yung stage 4. Pagka po mahirap na talagang gamutin, nakatatlong chemo agents na siya, nag-radiation na, nag-surgery na, or kaya hindi na po kayang operahan dahil sobrang laki na ng bukol, kaya sobrang hina na ng pasyente. Ito po yung nire-refer sa palliative care. Common din po sa mga non-cancer patients is yung stroke. Ito po yung mga bedridden talaga na stroke na kailangan talagang alagaan sa bahay. Sila po yung naka-NGT, yung nagbe-bed sore, yung mga ganyan. We also cater to patients with COPD. Ito po yung mga end-stage lung diseases. So COPD, emphysema. Tapos ngayon medyo dumadami na din po yung referrals for heart failure. Sila po yung mga pasyenteng manas na isang hakbang lang, nahihirapan na po or napapagod na sila. So dumadating din po talaga yung punto na hindi na kaya ng medisina, wala silang pampa-transplant ng heart, o pampa-angioplasty or open heart surgery, nagiging palliative care na lang din po sila. So nabanggit ko na yung end-stage kidney disease, meron din po yung mga Alzheimer's, meron din pong Parkinson's disease, meron din pong AIDS. Although yung AIDS, medyo nabawasan na siya kasi tipong nagagamot na yung AIDS. Although ang marami po sa AIDS, yung palliative care. Kasi yung mga ibang gamot sa AIDS, marami daw pong side effects. So doon po pumapasok sa symptom control ng mga side effects. So rabies, pasok po siya dito kasi wala po itong gamot. Once na hinawakan ka ng rabies or dinapuan ka, supposedly that's it. So dapat merong palliative care pagka may rabies or merong hospice care. Yung MDR-TB po, ito po yung multi-drug resistant tuberculosis. So kung na-reach din po niya yung end stage, para din po siyang end stage lung disease. So what are the specific services provided by palliative medicine and hospice care? We pride ourselves po in doing impeccable symptom control. So dapat dyan po kami magaling. Yung psychosocial, yung spiritual support, secondary lang po siya. Pero pagka bago lang po sa pandinig yung hospice or second-hand information, usually ang iniisip nila it's more of counseling. Pero counseling po is secondary. First and foremost should be symptom control. And again, like 66% of patients with cancer will experience pain. So dapat magaling sa pain control yung palliative care specialist. So we also help with difficult communication issues like yung nahihirapan pong mag-disclose yung primary doctor. Meron kasing art of disclosing, meron din pong science. Yung iba po gifted magsabi na meron pasyente na merong malubhang sakit, merong iba hirap na hirap. So pwede naman pong hindi pilitin, hingi na lang po ng tulong para mas makaigi dun sa pasyente. So pwede dun po yan i-cover ng palliative care specialist. So, ito yung isang pwede mong gawin for patients with stage 1 or stage 2. You can provide assistance with information sharing. You can give them an overview of what might happen in the future, kung gumaling siya or hindi siya gumaling. Assistance din po with decision making. There are many referrals to the service. Simpleng trach care, yung maglalagay po ng tubo sa leeg kung medyo 2 linggo na po silang naka-intubate or nakakabit sa ventilator. Kailangan na po kasi yung ilagay sa i-convert to a tracheostomy tube. Pero marami pong mga patients hindi nila naiintindihan. So kailangan po talagang upuan at bigyan ng oras para may paliwanag sa kanila. Tapos let me just clear things. Hindi po namin job na convince sila. Ang job lang po namin is to lay down the options for the patients. Sila pa din po dapat yung mag-decide. So we're here also for goal setting. Pag naintindihan na nila na maigi kung ano yung mga problema, kung ano yung situation, mas maganda yung magiging goals nila. Tapos kung papauwiin na po yung pasyente for home care, pwede din po namin yan i-service, which is yun po yung topic natin. So we also cater to end-of-life care. So kung inabot na po sa hospital or kung gusto nila talaga sa hospital doon mag-transition from this life to the next, we provide end-of-life care. So Ang hallmark po ng end-of-life care is to make the patient as comfortable as possible. And most of the time, this is achieved by giving comfort medications. So may isa pa pong usual service na binibigay yung palliative care or hospice care. Ito po yung palliative withdrawal of ventilatory support. Ito po yung tinatanggal yung tube kapag may dalawang doktor din pong nagsabi na mukhang futile na yung management. Medyo delicate po ito. So, kasi hindi pa po ito talagang tanggap sa ating bansa, saka hindi pa din po okay yung mga laws natin to protect the rights of the patients and also the rights of the family. Push comes to shove, pwede siyang gawin, pero kailangan maganda yung documentation. So, for our topic, we're gonna talk about home care and bereavement care. So, again, mag-focus na tayo sa home care. Ang tanong is, pwede bang alagaan ang pasyenteng may malubhang sakit sa bahay? Ang simpleng sagot ay oo, katulad po ng mga narinig natin kanina doon sa mga nagsalita. Nung in-interview sila, some of them are already taking care of their families at home. Ang big question at ang mahirap sagutin is, paano ba yung tamang pag-alaga? At meron bang tamang pag-alaga? So, let me just give you an overview of what home hospice care. It's an essential aspect of end-of-life care support. Focusing on comfort, dignity, and quality of life for individual with terminal illnesses. So parehas lang din po ng regular palliative care and hospice care. So ang principles of home hospice care is there should be emphasis on comfort and quality of life. Only a patient can tell what is a good quality or what a definition of quality of life is. Pag tinanong niyo po yung estudyante ng medisina kung anong definition ng quality of life sa kanya, sasabihin niya yung makatulog siya ng mahaba, yung hindi siya pumasok kasi pagod na siyang mag-duty. So, meron pong pasyente ako dati na ang problema is heart failure. Hindi po niya kayang magsipilyo on his own. Yun po yung quality of life sa kanya, yung makapagsipilyo ulit ng sarili. So, good thing is, yung nabawasan po yung manas niya, natupad naman yung quality of life kasi nakapagsipilyo siya ulit. So, simple lang, di ba? Sipilyo lang, pero yun na yung definition niya ng quality of life. So the other principle of home hospice care is providing support to both the patient and their family. So nakakalimutan po natin pag sa bahay, yung stress ng pasyente, meron pong pag-aaral na yung stress nung nagbabantay or nung nag-aalaga, kasing stressful or kasing tindi ng stress ng pasyente. And there are even studies na nagsasabi po, mas matindi pa yung nararamdaman ng mga nag-aalaga. So kaya pag nagbibisit po tayo sa bahay, hindi lang po yung pasyente yung tinitingnan, pero tinatanong at kinukumusta din po natin yung mga nagbabantay, including po the caregivers. So what's nice with home hospice care is that the patient's wishes and yung tinatawag na patient autonomy, kasi siya yung dapat na nagde-decide sa kanyang sarili, nire-respeto po. So what are the services provided in home hospice care? Again, it's the same. It's similar to what's being done outside of the home, pain management, symptom control. Pero meron pong highlight sa nursing care. Pag nasa hospital po kasi, ang gagamot ng wound, nagbibigay ng mga medicines, nagbibigay ng nursing care, yung mga tao sa hospital. Pero pag uwi, kung meron pong budget yung family or kung meron tayong makukuhang libre na magpo-provide neto, maganda. Pero ang problema, kung wala po, it's usually the members of the family who assume the roles of nurses, caregivers, and even physical therapists. So yun yung challenge. So tinuturuan po natin sila sa abot ng ating mga kaya. So again, emotional, spiritual, social support, both for the patient and the family is very important. Sabi nga kanina, paano na yung, kung sila yung mawala, di ba? So kung sila yung bumigay. So that's why we always advise families going home na hindi po sapat ang isang caregiver o isang nurse, kasi syempre alam niyo naman po mahal, pero kailangan po talaga at least dalawa. Kasi kung isa nga lang, masipag siya, bibigay po eventually. So pag bumigay na yung nag-aalaga, makikita niyo po yun dun sa pasyente, lalo na kung stroke patients. Magkaka-bed sore na yung pasyente, magkakaroon naman ng problema, So that's why equal po yung importance nung pasyente at nung nag-aalaga and the family. So we also assist them with the daily living activities. So we teach them how to take care of the NGT, we teach them how to feed, we teach them how to take care of the colostomy tubes or the colostomy bags. So caregiving in home hospice, as was stated a while ago, yung family members and caregivers na-heighten po sila, na-elevate sila, na-promote sila to becoming nurses and caregivers. Even if that's the case, kung di talaga po kaya hire or maghanap ng libreng caregivers or nurses, yung communication and collaboration with the healthcare professionals is paramount. So ito po yung ginagawa namin kung ganito po yung situation. So iniiwan po namin yung number namin. So kung magkaroon po ng problema, pwede nila kaming tawagan. Tinuturuan din po namin sila ng mga what to watch out for para alam nila kung kailan sila patawag. So balancing caregiving responsibilities with self-care, ito po yung tinatawag na caring for the carers. There was a mention of respite care. Ang tawag po dito respite care. So pag pagod na po yung nag-aalaga, dapat po magre-rest din siya. I remember when I was, I think, a fellow, nag-aaral pa po ako ng palliative care. May binibisita po kaming pasyente sa Tondo. Mas maganda pa po yung itsura ng pasyente kaysa dun sa nag-aalaga. Yung nag-aalaga, ang gulo-gulo ng buhok. So ang ginawa po namin, naghanap po kami ng mag-aalaga for the day, then pinag-day off po namin siya. Tapos yun, naka-recover naman po siya. So challenges and considerations. So it's hard to take care of a patient at home. The impact on the emotions of the caregivers and family members, as mentioned, is sometimes even more compared to what the patient is feeling. So ang iba pang challenges is yung decision making regarding end-of-life care. Minsan po sa hospital, sasabihin nila, hindi na nila dadalhin sa hospital pag nakauwi na. Pero pag nasa bahay na, nag-iiba na po yung decision making. So you have to be aware of these changes. Di mo naman po pwedeng sabihin na di po kayo pwedeng magpalit kasi yun na yung decision ninyo. So sila pa din po talaga yung masusunod. So again, I think the communication with the family is very important. So we also should consider a comfortable and supportive environment at home. So yung daily visits, yung weekly visits kung kaya, or twice a month visits ng doctor, very important yan sa family. Hindi lang naman po doktor ang nag-visit, meron din pong nurses, at meron din pong ibang staff ng home care team. So home hospice care, ang pinagkaiba lang niya dun sa regular hospice care is that the care is done in the home and not in the hospital, and the members of the family have a bigger role. Tapos tama po yung mga nagsalita kanina. So ang benepisyo ng home hospice care is it saves a lot of money. Mas matipid siya kumpara kung nasa hospital yung pasyente. I remember one patient before saying na pag pupunta po kami sa doktor namin sa OPD, pag mag-follow kami, production number. Kasi bedridden yung pasyente, so lilipat nila sa wheelchair or sa stretcher, lilipat nila sa sasakyan. Most of the time, hindi kasya, so mag-hire pa sila ng ambulansya. So sobrang mahal po talaga. Pupunta lang sa OPD. So at least pag home hospice care, kung charity siya, wala pong bayad. Pero kung may bayad man, at least I think mas mura compared to dun sa production number. So what's nice also with home hospice care is that the patients are in the comfort of their home. So sila yung siga. So sila ang may-aring bahay. So iba yung kama mo yung tinutulugan mo, iba yung unan mo yung nasa likod ng ulo mo, di ba? So mas maganda ka. So, mas maganda yung pakiramdam. So patient autonomy is also respected. So this is one of the ethical principles that's widely used in palliative care. Kasi dapat yung pasyente ang nasusunod basta naintindihan niya. And also within the norm of non-maleficence and beneficence in terms of the principles of ethics. Meron pong sinubmit or meron pinopose si Senator Miriam Defensor Santiago before na bill na supposedly magpo-protect ng rights ng mga pasyente kapag terminally ill na sila. Pati po yung rights and welfare ng mga doktor natutulong dun sa pasyente. Kaso hindi po pumasa I think hindi po pumasa sa Senado eh. So hopefully, sana po magkaroon tayo ulit ng ganon para lahat po yung full extent ng palliative care service maibigay natin dun sa mga nangangailangan. So again, care and comfort is ensured. What's important is that it is in their own terms. So in the Philippine General Hospital, which is the apex hospital for hospice and palliative care, dito din po nagsimula yung palliative medicine at hospice care noong 2002. Yung Department of Family and Community Medicine is the one providing the home care of the hospital. So as of November of this year, we did a total of 132 home visits. Ito lang po, natigil lang po yung service nung nagkaroon ng COVID. Yung service lang ng home visit. Pero yun pong service ng palliative care, nandyan pa din po siya kahit merong COVID. Kasi hindi naman po mawawala yung mga cancer patients o yung mga pasyente na nangangailangan. So yung home care po, it's being done twice a week, Mondays and Fridays, catering to patients within the 10-kilometer radius of PGH. Kung lampas mo ng 10 kilometers, we try to network to known services in the area, or kung wala talaga, tele or video consult. Ang mga common po na nire-refer namin is yung Ruth Foundation sa Muntinlupa at saka yun pong Madre de Amor Foundation na nasa Los Baños, Laguna. Yung mga iba po, hinahanapan na lang namin ng mga doktor na parehas ang puso at doon po namin sa kanila nire-refer. So I think the important thing here is that the family can hear a familiar voice kung di talaga makavisit, see a familiar face, to help them cope and have someone oversee and give advice as to what is happening. Sometimes po ang kailangan lang nila yung may magsasabi sa kanila kung anong gagawin kahit alam naman na nila kung ano yung gagawin nila. Alam naman nilang dadalhin nila sa ospital kung yun talaga yung gusto nila, pero kailangan nila na magsasabi, dalhin mo na sa ospital. So, hospice home care usually starts in the hospital. So, the usual form of referral is, ngayon po text-text na lang, although sinusulat pa rin sa chart. So, nakalagay dyan, transition of care from hospital to the home. So, what the team does is, na-assess po natin yung needs ng pasyente. There's a growing trend of changing from prognosis, yung mga malubhang sakit, kung sino yung mga nangangailangan ng service. So, yun po yung ginagawa natin. Tinatanong natin kung ano yung mga kailangan ng pasyente. So, pag nakuha natin yon, we ask them what their goals are. Hospital ba? Home ba? Cure ba? Care ba? All out? Or palliative? Tapos pag nakuha natin yon, we can prepare a plan of care for them. So, most of the time, it's the equipments. Meron na po kaming listahan. Depende po dun sa situation ng pasyente kung ano yung mga kailangan nila. Nakaready na po rin yung mga linkages with third-party nursing organizations. So kung walang kamag-anak na willing maging caregiver, so binibigay po namin yung mga third-party nursing organizations. So we also provide crash course caregiving skills. Although umpisa pa lang sinasabi na naman sa kanila na kung ganun talaga yung magiging ending, hindi nila kayang mag-hire or wala silang makikitang libre, panoorin na yung mga ginagawa ng mga nandun sa ospital or paturo na para pag-uwi, marunong na sila. So we also provide a list of medications with prioritization. So pag hindi nyo po sinulat yung mga listahan ng gamot ng mga pasyente nyo, kadalasan ang bibili nila yung pinakamura, vitamins or aspirin. So mas maganda po kung nakasulat yung gamot, para saan siya, kung siya ba yung pinaka-importante. Kasi doon po nagkakatalo-talo. Katulad po nung pasyenteng heart failure na binanggit ko kanina, so hindi niya bibilin yung ACE inhibitor o yung talagang pinaka-importanting gamot. Ito po yung dati pa for the ACE inhibitor, kasi bibili niya yung mura eh. So kung i-identify niyo po sa kanila which are the top 3 medicines that they should take, okay. Tapos yung all-important endorsement letter, papakita ko po ito sa inyo mamaya. So para mas maintindihan po natin siguro, I'll lift some of our patients para ma-share ko po sa inyo. So, patient number 1, CMI, 64-year-old female po siya from Manila. Ang diagnosis niya, rectal cancer stage 4. Kumalat na po yung cancer sa liver at saka sa lungs. Meron na po siyang tubig sa lungs. Tapos medyo naninilaw na po siya. So, pag sinabi pong stage 4, yan po yung medyo advanced na yung cancer. Mahirap na siyang malunasan. So, ang reason po for referral to the service, to hospice, is for pain control that eventually transitioned to home care. Nung na-control na po yung pain ng hospice, nag-request na din sila na umuwi. Yung mga contraptions, ito po yung mga nakakabit sa pasyente. So, meron po siyang NGT, doon po siya kumakain, doon umiinom ng gamot, at saka meron din po siyang colostomy bag because of the rectal cancer. So, what needs to be highlighted, yung ACDs po, ito po yung advanced care directives. Ito po yung listahan ng mga pwede niyang pagdesisyonan pag malapit na po siyang pumanaw. Pangit man sabihin, pero ito po talaga yung mga usual na pinag-uusapan pagka sa hospice. So, yung advanced care directives niya, yun po yung magpapakapit po siya ng tubo at ikakabit sa ventilator pag nahirapan siyang huminga, i-CPR pa po ba siya or ipapump kung tumigil yung heart. Ayaw niya po itong pag-usapan nung nasa ospital. Sabi ng pasyente, pag-uwi ko na lang. Tapos I would also like to uh, mention that the medications of this patient is a fentanyl patch. So siguro most of you have heard of fentanyl as an anesthetic. Pero dito po sa palliative care, we're using it left and right. Morphine, fentanyl, kasi yan po yung mga gamot talaga na indicated for pain. Meron pong paracetamol for mild pain, merong tramadol for moderate pain, pero kapag severe na po yung pain at cancer pain siya, hindi na po ubra yung tramadol. Dapat po talaga yung mas mataas na uri na ng gamot for pain, which is ito nga po yung fentanyl. Hindi po kami nagbigay ng morphine because the liver enzymes are quite high and the creatinine is also high. So nung unang panahon, pwedeng mag-morphine, i-reduce mo lang yung dose. Actually, pwede pa rin naman po, but there's a better alternative and that is fentanyl. So when we saw the patient in the hospital, jaundice na siya. Nung umuwi siya, mas jaundice pa siya. Tapos highlight ko lang po na the number of times of visit that we visited this patient was only one. But there were many things that were done during that visit. So one is the reinsertion of the subcutaneous line. So pag umuwi po yung mga pasyente namin, hindi po kami masyadong gigil na naka-IV siya. Pwede naman pong wala. Maraming studies po kasi na kapag naka-IV line, merong dumadalos na plain NSS or whatever. Mas lalo po silang nagmamanas, pwedeng pumunta sa baga, lalong mahirapan huminga. Hindi naman po nila yun kailangan. So explain po namin yun na maigi. So a better alternative to give medicines to the patient is through a subcutaneous line. So paano po yung ginagawa? Same lang din po ng pagkabit ng IV line, pero dun sa mga areas na usually ini-inject yung insulin, doon po namin siya kinakabit. Tinatanggal yung bakal, iniiwan na lang siya doon, tapos i-replace every 3 to 5 days. So what we also did when we visited this patient is we reviewed the essential medicines. Dami po kasi niyang gamot, so tinanggal na po namin yung mga hindi niya kailangan. So iniwan na lang namin yung mga very important. So we also provided psychosocial support to the patient. Kinausap namin po siya ng mag-isa. Sinabi niya na gusto niya talaga sa bahay na, alam niya na malapit na siya. Gusto niya manood ng telenovela, K-novela ang gusto niya. So, sinabi din po namin yun sa actually, meron naman po siyang widescreen TV na malapit sa kanya. So, yung husband po niya, marami din apprehensions, although he was the one who really was supportive of his wife going home. So, medyo nagigilty lang daw po siya kasi yun nga yung iniisip niya, no? Baka mali yung naging decision niya. So, yun po yung in-address namin dun sa husband. Yung son naman, sa willing financial provider. So, sinabi namin sa kanya na okay yung pagpatuloy lang niya kasi siya lang yung pinakamalakas dun sa family nila. And also the caregiver, kasi yung caregiver, siya po lahat. Siya yung nagbibigay ng gamot, siya yung nagre-report dun sa husband, although katulong din niya husband. So, within this loan visit, we were able to set the goals and end-of-life preferences. Ayaw lang pala niya talaga sa hospital na pag-usapan. Pero nung nandun na po sa house, mabilis lang yung usapan. Sinabi niya, pag nag-stop yung heart ko, huwag niyo na po akong ipump, huwag niyo na akong dalhin sa ospital, huwag niyo na akong i-check. So foremost, this is where the care ends pag nakuha mo na yung DNR-DNI. But for the hospice specialist, this is where the job starts. Kasi paano kung nahirapan huminga? Remember, this patient has lung metastasis, so there might be this tendency na magkaroon ng tubig sa lungs. So doon magsa-start yung problema mo, di ba, as a hospice care specialist. So i-discuss na po namin yun sa pasyente na pag nangyari yun, pwede tayong magbigay ng diuretics, pwede din po tayong magbigay ng medicines na that will help the patient not feel the difficulty of breathing. Ito na po yung mga tinatawag na comfort medication. So ito na yung fentanyl ulit, kasi hindi pwede ang morphine. Tapos kung talagang nasa dulo na po, meron pong binibigay na gamot na ang tawag is midazolam. Yung midazolam, ala din po siyang anesthetic, pampatulog din po siya, pampakalma. Ang purpose po ng pagbibigay nito, hindi para patayin yung pasyente, hindi po ito euthanasia, kasi ang goal naman po natin ay hindi patayin ng pasyente. Ang goal natin is to provide comfort. We're always careful and we always remind our patients na kapag magbigay po ng midazolam, ang half-life po noon or ang time na nandun sa body ng pasyente, 4 hanggang 6 na oras lang. So kung hindi pa po niya time, it's not the time of this patient to go, then magigising siya ulit. So kung in distress siya, pwedeng in distress siya ulit. So that's why we're going to offer it again. And kung palaging ganun po, every 4 hours, every 6 hours, baka mas maganda kung drip na siya. So pwede bang drip sa bahay ng midazolam? Pwede. Subcutaneous? Pwede. So ensuring yung last bullet po is this is the last service that we did for this patient. We ensured that they can call us anytime. And yun nga po yung nangyari. After 2 days, they called us and informed us that the patient died in her sleep. So this is the best form of exit for me. This is the way I want to exit as well. Hindi na po tayo nagbigay ng midazolam. Hindi na natin in-increase yung fentanyl patch niya. Ang sabi nga po nung husband, mukhang hinintay lang po, Doc, na sabihin yung mga gusto niya. Tapos, yun na. Pagkagising po nila, wala na siya. So that's patient number 1. This is how her endorsement letter looked like. So makikita niyo po dyan. Ito po lahat ng pasyente na i-discharge namin, meron ganito. This will benefit the home care provider kasi makikita niya ng lahat kung ano yung meron yung pasyente. Nandito po yung details ng pasyente, nandun yung condition niya prior to discharge, GCS 15, weak looking, nandyan yung vital signs, nandyan po yung diagnosis, nandyan po yung psychosocial profile, kung alam na po ba ng pasyente, kung kailangan pa bang ipaalam, alam ba ng family, sino yung decision maker. Nandyan din po yung mga home care plans, yung pagkain, paano ipakain, NGT po ba, gano'ng karami, yung mga gamot, katulad ng minention ko kanina. Nandyan din po yung take-home medications ng mga ibang specialties, kasi importante din po yan para alam ng family. Pati po yung equipments nandito, pati po yung mga home care instructions kung anong mga dapat gawin, what to watch out for, pati po yung monitor. So ngayon, essential na sa bahay na meron kang pulse oximeter, pang-test ng sugar, BP, pero pulse oximeter malaking bagay. So ito pa po yung mga ibang important things in the endorsement letter. Importante po yung contact number nung tatawagan nila if there's an emergency. So I think that's the most important thing. Kasama din dito yung mga important laboratories. So let me proceed to patient number 2. So hindi naman po palaging malungkot. Meron din pong pasyente na masaya. And this patient is the masaya patient. So she's BP 91 years old from Makati. She was referred to us for home care. Pero nung na-refer po siya sa amin, tinest siya for COVID. Unfortunately, positive siya. So na-delay pa siya ng mga 14 to 21 days before siya nakauwi. Ang original problem po was pumutok po yung ugat sa brain. So it's a stroke that is in the form of a bleed. So meron din siyang heart failure, hyperthyroidism, so marami po siyang sakit. Nung umuwi po siya, meron siyang NGT, meron siyang Foley catheter, tapos ang advanced care directive niya, full code, meaning lahat gagawin. Understandable kasi hindi naman po siya cancer, wala naman po siyang tanning. Pero if you would have seen her when she was discharged, sobrang lambot na lambot, sobrang hinang-hina. Ang dami-daming gamot. So the number of times we visited this patient is I think 19 including the teleconsults. Ang maganda po dito sa patient na to, meron po siyang 2 caregiver. Ang hindi maganda, ang family niya nasa abroad. So ang family niya na dito, yung 2 caregiver, 2 nurses, tsaka yung pong mga nagvi-visit sa kanya. So she always looks forward to the visits of the hospice care practitioners. So the services done for this patient, na-remove po yung NGT and Foley catheter without her going to the hospital. So ang nag-remove na po nun, yung mga nag-home visit. Na-save din po yung time nila kasi ang daming doktor neto. So good thing yung iba merong teleconsult, pero eventually na-discontinue na din po yung follow-up with the other specialist kasi kaya naman na yung home hospice care. So again, there's a reduction in the number of medicines from 20 plus. I think it's now just down to 4. The psychosocial support to the patient, importante, kasi nga, mag-isa lang siya. Same with the nurses. May mga, minsan nagtatampong mga nurses, umaalis, pero buti bumabalik. Tapos, ang isa pa pong magandang nangyari dito sa pasyente na to, nung nagka-stroke siya ulit, we were able to catch her in the best time of the stroke kasi nakapag-administer po ng antithrombolysis. So the effects of the stroke were minimized, although we had to start from scratch again. But at least now she's back to where she was before. It's a good thing na Alam nila yung gagawin, alam nila kung saan pupunta, sino yung tatawagan. So yung mga ganun po ba, kung walang ganun, walang preparation, baka bedridden na talaga siya. So some of the common illnesses at home, like nagka-pneumonia siya, nagka-shingles, nagka-UTI, kayang-kayang i-manage. And again, ensuring that they can call anytime that admission will be facilitated is there. So ang outcome po nito, ang pasyente natin currently has no contractions, she's eating on her own, she's walking, she's going to the mall. So hopefully, she will stay that way for a longer period of time hanggang maka-reach siya ng 100. So last patient is patient EF. He is a 76-year-old male from Cavite. The diagnosis is prostate cancer stage 4. Meron pong bone metastasis and liver metastasis. So kumalat na po sa bone and the liver. So the reason for referral is again for home care and pain control. May Foley catheter siya nung umuwi, pero sila po decided na, dalawa lang po kasi sila nung wife niya who's also around 70, na hindi na sila magpapadala sa ospital, sa bahay na lang talaga, kahit anong mangyari. So ang mga medications po niya, luckily, morphine lang kasi mas mura po yung morphine. Naka-dexamethasone po siya kasi ito po yung nag-work for his bone pain. Naka-standby midazolam and standby chlorpromazine. Yung midazolam and chlorpromazine, overlapping po sila kasi meron request si mami na hindi po kayang uminom ng pasyente, baka pwedeng sa rectum or sa ibibigay na lang rectally yung gamot, which is what exactly happened to this patient bago po kami dumating nung pumunta kami nung timeline. So, number of times visited is 2. Yung first visit, nag-change lang kami ng Foley, inayos namin yung pain. So, adjustment of pain medications, replacement of Foley catheter, reduction again in the number of medications, psychosocial support to the patient and the wife, the assurance that we are just a call away, instructions how to administer rectally kasi yun yung preferred ng pasyente. And we were there when this patient died kasi nga po nag-distress yung pasyente na talagang parang hindi naman siya nagwawala pero balisa siya. So dumating po kami, nagbigay kami ng mga gamot like yung midazolam. Ayaw po niyang magpakabit ng subcutaneous ayaw din niyang IM, ayaw oral. So talagang rectal po namin pinadaan yung. So patient developed difficulty breathing, became restless, but eventually passed away comfortable, peaceful after the administration of the comfort medications. So one thing that we do po for patients that we do home visits to is the accomplishment of the death certificate. So there are many doctors that shy away from signing the death certificate. Kami po, amin na ang death certificate. Kami na yung mag-fill up para hindi na po mahirapan yung family. Hirap na sila, namin na lang nangyayari, di ba? Meron naman pong box na pwedeng i-tick dun sa death certificate na not attended to. So benefits of home hospice care, as mentioned, saves money. They are in the comfort of their home, autonomy or their decision is respected, and care and comfort is always ensured in their own terms. So what happens when the patient dies? So ideally, the specialist or the home visit or home care provider should be at bedside to offer sympathies and condolences and also to answer questions. But this is not always the case. So sometimes, kung hindi talaga kaya, a telephone call or video call is also will do. What is important is to guide them by telling them the process. Pag na-confirm na po talaga na hindi na humihinga, ang dapat pong tawagan hindi na yung ER, kundi yung funeral service. Tapos sila na po yung magbibigay ng requirements until the signing of the death certificate. Pag nakausap niyo po sila, kumakalma naman sila. Naiintindihan nila kung ano yung dapat. So this heralds the start of the bereavement process when you start talking to the family. And what is bereavement? It's the care that's being given to the family of the loved one who are left behind. So bereavement includes emotional, psychosocial, and spiritual support provided to the family after the death of the patient to assist the family in coping with issues related to grief, loss, and adjustment. What we usually do is message or call our patients immediately after death. Then following the Filipino traditions, dito po namin sinusunod kung kailan kami tatawag or makikipag-communicate. So pasyam, yun pong 40 days, and then 1 year after pagbabang luksa. Kung ano po yung ginagawa natin pag pumupunta tayo sa wake, ganun din po yung ginagawa namin. So there's not much difference. It's just showing up to provide support to the family, and that is bereavement care. So ang difference lang kapag doktor, tinitingnan po natin kung merong complicated grief. So kung let's say 1 year na, hindi pa rin po nakaka-adjust, baka yun yung time na kailangan natin magkaroon ng intervention. So when done well, bereavement care, most people will feel strengthened, encouraged, and supported when they learn that grief is normal, it is a process, and it takes time. So ito po yung aming paggunita program sa PGH. We do it yearly. Ang mga attendees po dito, yung mga namatayan, na bago, yung mga namatayan nung isang taon o nung mga nakaraang taon. Nagkakaroon po ng sharing kung how well they cope, at kung sila na po yung nagbibigay ng advice dun sa mga bagong namatayan. So yearly po namin yan. So, in a nutshell, to summarize, the provision of hospice and palliative medicine is the provision of holistic care to patients, children and adults and their families with serious illness. The care po is provided in the hospital, at home, and in dedicated centers and facilities. The important services to remember: symptom control, excellent communication that will provide better illness understanding, guided treatment decision-making, informed goal setting. So minsan po pag alam na nila, nalaman nila na stage 4 na pala, mahirap na pagalingin. Yung iba hindi na nagbebenta ng kalabaw, hindi na nagbebenta ng bahay or ng lupa. At least mas napaplano po nila ng mas maganda. Ibang usapan kung stage 1, syempre, dapat magbenta kasi sayang ang buhay. So one important service to remember also is to address the patient and the family, including advanced care directives. End-of-life care is an important service, and as we've discussed, yung home care and bereavement care. So again, don't forget, the mantra is the provision of the best quality of life possible in their own terms. So home hospice care is the same palliative hospice care, except that it is done in the home of the patient, and bereavement care is taking care of the loved ones who are left behind. So lastly, and as promised, ang UPPGH po, Supportive Hospice and Palliative Medicine, meron po kaming hotline. This is a number that we give to all of our patients. Meron pong naka-duty 24/7. So if you know somebody who will benefit from the service, call lang po kayo or message lang po kayo. So we also have our Facebook page, PGH SHPM. Yan po yung Facebook page. Diyan po yung link para makapunta po kayo dyan. Paki-like na lang po. Tapos to end, here are some photos of our home visit program. So yan po siya. So yan yung mga pasyenteng binivisit. Pag nagbivisit, minsan mayroon pong mga estudyante, mayroong mga doctors na galing po ng mga ibang provinces just to see how the program goes. So hopefully nakikita niyo po yung smiles ng pasyente, not just the carers. Yan, naka-peace sign pa si tita. Ito medyo hindi po siya capable of doing the peace sign, pero kita niya po yung maraming contractions, oxygen tank sa likod. So yan po, naka-smile. At least nasa bahay sila, diba? Yan, naka-oxygen tank. Naka-oxygen support. Ito po, naka-smile. Ito si Lolo na tinitingnan ko ano yung po. So this is the last slide. Marami pong salamat.
Oh, thank you
Wow,
very
okay.
much. Thank you very much, Dr. Andrew, for an excellent presentation. Galing. Talagang nakadikit ako sa screen at tinitingnan ko. Ang ganda talaga. Very nice. And you'll see the appreciation of our listeners. I'm sure there are a couple of questions coming up. Please put them in the Q&A box. And Raymond, over to you. Ganda. Thank you so much.
Thank you, Dr. Susie. Thank you also for those 3 case studies, Dr. Andrew. Very important po just to get like the human aspect for how they were taken care of. We'll expect you, sir, during the Q&A. I will just move ahead with our reaction from our reactor po. And for our reactor, but before I introduce her, just to remind everyone that if you have any questions, please put it in here sa Q&A box sa Zoom po, or you can type it in the comment section sa Stop COVID Deaths or TVUP Facebook pages or in the TVUP YouTube channel po. Okay? Our next speaker is our webinar reactor, who is the immediate past president of the Philippine Society of Hospice and Palliative Medicine. She also serves, suki na po natin siya, but very, very thankful that she's also here again, lending her time and her expertise. She's current chair of the UPPGH, Department of Family and Community Medicine. Please welcome again, Dr. Karin Estepa Garcia. Dr. K.
Yes. Thank you, Dr. Raymond and Dr. Susie. I hope I am given the permission to share screen. Ayan. So, sana nakikita na po lahat. And I'm happy again to be back here in the TVUP. Thank you for the invitation. I am now going to talk or react on hospice and palliative care. So kung yung binigay ni Dr. Andrew Ang is how we provide the service, what are its inclusion, siguro dahil marami tayong audience from all around the country and even in other countries as well, ano bang nangyayari sa national level, no? Ano bang experience natin sa palliative at sa hospice care? So sisimulan ko lang po sa pagbibigay ng aspeto kung nasaan po tayo worldwide. Alam natin na ang Pilipinas ay nasa around 170 million population po tayo. And important sa amin na malaman kung ano ba ang life expectancy. So from 69, nag-increase na po tayo to 70 years old. And that means our age, our lifespan is increasing, and it entails also diseases that are accompanying the aging process. And yeah, at top mortality natin are really still non-communicable diseases. Actually, yung mga cancer is part of palliative care, but we also really take care of these other non-chronic diseases. Kung ikukumpara natin ang Pilipinas sa ibang bansa, tayo po ay nasa Group 3A country na ang provision ng hospice at palliative care is isolated. Huwag po tayong malungkot dahil nagsimula po tayo sa level 1. At ngayon po, umakyat na po ang ating bansa to Group 3A. But of course, we want to go into level 4B where there is advanced integration already. At ikukwento ko dito, paano ba natin ito ma-achieve? No? So just a short history, kailan ba nagsimula ang palliative at hospice care sa Pilipinas? Actually, yung konsepto po na ito, since the 1980s pa po, no? Medical and civil societies, it started really in the community. Hindi lang natin alam na ito palang itong ginagawa natin is already hospice and palliative care. And then nagkaroon na po, no, naging deeper yung pag-aaral dito at na-integrate na rin siya even sa mga doctors, no, that there is now a subspecialty training for physicians. It started in UPPGH, but now we already have, I think, 6 or 7 institutions nationwide providing specialist training. Ang gusto ko lang iparating, yeah, may specialist training, pero ang nangangailangan ay nandoon din sa ating komunidad, no? So, ayan na po, no, 2010, nagkaroon na rin po ng mga societies, and then now, at 2020, the National Palliative and Hospice Care Program. Maganda rin po ang timing na ito dahil we have 2 landmark legislations that happened. First is Republic Act 11215 o ito po yung NICA Law, the National Integrated Cancer Control Act, and the Universal Healthcare Act kung saan ang service coverage nito includes curative, promotive, preventive, curative, rehabilitative, and palliative care. So, kung ganun kalawak ang service coverage ng universal healthcare, kailangan mag-act po tayo, no? So ano po kaya ang mga challenges na nakita natin, no? How can we provide this service to the 117 million Filipinos that might actually need it, no? So we do understand meron pa rin tayong mga health inequalities. Okay? It's still there to deliver the quality health care which includes palliative and hospice care, lalo na sa mga geographically isolated and disadvantaged areas. There are still fragmented efforts among the stakeholders in the implementation of this kind of service. No? So kasi gusto natin sana across the service delivery, across all levels of care. So hindi lang siya sa hospital, but even down to primary care. And there is low awareness or even lack of awareness of healthcare professionals, okay, in the need of palliative and hospice care. Ito medyo challenging ito kasi baka talagang kailangan tingin pa natin, paano ba natin ito malalaman na itong pasyente na ito really requires already this kind or type of service. And lastly, medyo meron tayong, we need to really look into impaired health and medication literacy not only among patients, but even those that provide this. So there are may mga barriers po dyan, yung medyo resistant for giving such medications that will provide comfort. So ito yung nakita po ng those who are advocates and working for hospice and palliative care, the challenges. And dahil po dyan, sabi ko nga po kanina, may mga legislation, tayo na po ay nag-action. So right now, lalo na po nung pandemic, lumabas na po ang National Palliative and Hospice Care Program. It is a manual of operations, procedures, and standards to help clinics, to help hospitals, to help those in the LGU start this kind of service. Kasi parang, how can we actually take care of those in the community if we are not guided as well? So, dahil in-highlight ko lang po, no, dahil may health inequalities, may impaired health medication literacy, and fragmented efforts, this really talks about capacitation. Dahil kung sa hospital lang talaga tayo nakafocus, we might need to provide the numbers and the quality of care that our patients need down in the community level. And this is actually the success of primary health care, as stated in the Astana Declaration, which is to really capacitate people and to make sure that each person can actually provide, those who are in the barangay health, the barangay level, those in the community. Alam nila, they can for them to recognize, not even provide that care. That recognition is very important already. And then we do have a very good, at service level allocation is provided. Okay. So sabi ko nga, medyo kailangan matutunan ng ating mga tao yung training for hospice and palliative care. So this is now the training framework that I want to share na from the basic level, from the community, going up to rural health hospitals, going up to secondary hospitals, and even to apex hospitals. Sana po we are providing this kind of training for all. And across all life stages po, no? Hindi tayo namimili ng pediatrics, geriatrics. Anybody can actually need this kind of service. So so if we teach those in the community, if we go up for intermediate or even advanced, so we are ensuring of the quality of care that can be provided. Actually, just to inform everyone, for family and community medicine, at the 139 training programs nationwide, it's actually part already of the foundation course. Hindi sila pwedeng makagraduate kapag hindi nila nakukuha ang hospice and palliative care. These are primary care physicians who will go back to their communities, who will work in hospitals or in other places, but that is yung konsepto na nandun. And also we're working very hard with the nurses. The nurses, we cannot work without nurses, no? Sila ang bedside, silang daw ang nakakakilala sa mga pasyente, and they need to be equipped. So I think this one that we have piloted, they will also be an advantage. Ito lang yung laman ng ating courses na yon na ino-offer with the DOH. So yung basic na minention ni Dr. Ang, communication is there, grief and bereavement, hospice care. Kapag namantayan ka sa community, how do you actually deal with families? So we need to equip this, our barangay health workers or those volunteers in the community. And lastly, ito po yung gusto ko lang ipakita na ang ating national framework of hospice, where community and hospital shall both be part of the healthcare provider network. This network will actually encompass all levels of care. So, gaya natin ng guidance yung pamilya kasi sila po yung kasama ng ating pasyente sa home care. Maganda yung pinakita ni Dr. Ang na mga pictures. We need to equip the families. And going up, rural health units at the community, these are what we call compassionate communities. Ang compassionate communities, nanggaling yan sa isang universal golden rule to treat others as you would like to be treated. So yung sa India, they have this kind of mindset na pag nangangailangan ng isang tao sa aking area, at least I know how to refer where to get those equipments na kailangan. So I think it's a cultural a mindset change as well. But we're starting. Some communities have adapted to this. And then if needed, long-term care, then health facility-based care, then going up the ladder. Different approaches is there, the transdisciplinary, interdisciplinary, and multidisciplinary approach. Kasi ang vision natin is we need to, in order to achieve this, we really need to build commitments and cooperation among various stakeholders. Yung sabi ko nga, Group 3A, we want to go up the ladder, no? And an interoperable palliative care registry. Dapat nag-uusap-usap no? Kasi kung dito siya minanage at dinala siya sa probinsya niya, minsan ang communication doon mahirap, no? So it has to be interoperable. And we need to really lobby the laws with policymakers pertaining to the integration of hospice and palliative in the health system. And of course, yung information and sensitization campaign on compassionate communities. Na pag ginugol ko ang hospice and palliative care, hindi ako matatakot na ako ba mamamatay na? Bakit ako tinatawag dito? Ako ba ay ganito? So that kind of removing that mindset of fear to patients is something that really needs desensitization. So ang last ko lang gustong sabihin as a reaction, in hospice and palliative care, we do not add day to lives, but add life to your remaining days. So maraming salamat, Dr. Susie and Dr. Raymond.
Thank you so much, Dr. Kay. And really just framing po yung para sa training. Ano po yung klaseng training na nabanggit po kanina ni Dr. Andrew na konti lang po kasi yung train sa hospice and palliative medicine. Sana po ay may mga ma-inspire na pumasok po doon. Okay. We'll be going ahead just preparing lang po, no? While our panelists are taking like a minute to breathe po, no? I will take a very quick break for a special public service announcement for today.
O sige na anak, parang kagat lang ng langgam. Kantik o yung kumikiliti lang? Ito naman parang hindi ka pa nababakunahan dati. Akala ko pa naman brave girl ka. Nakakahiya na kay Doc.
Okay lang po, nanay. Ay, ang cute naman ng shirt mo. Favorite color ko rin yan.
Doc, favorite ka rin po ang color nito. Pero ayoko po ng red huntik. Masakit kumagat at takot rin po ako sa blood. Magtutugo po ba ako sa bakuna?
Ah, hindi. Walang dugo sa bakuna. Konting pisil lang, tapos na.
Kakasugat ba ako, Doc?
Hindi ka magkakasugat. Lalagyan lang natin ng plaster pagkatapos para safe. Di ba nabakunahan ka na rin ng contra measles at chickenpox dati? Parang ganun lang din ang bakuna para sa COVID-19.
Natatakot pa rin ako, Doc.
Alam mo ang secret sa pagiging brave. Hindi ibig sabihin na wala kang kinatatakutan. Kundi, kahit natatakot ka, hinaharap mo pa rin ito.
Okay. Ready na po ako, Doc.
Una, pupunasan ko muna ng bulak na may alkohol ang braso mo. Okay? Tapos, mabilis lang na konting... Ayos! Tapos!
Tapos na, anak. Pwede mo nang buksan ang mga mata mo.
Nay, sabi sa inyo, brave girl na po ako eh.
O heto ang prize para sa'yo, ha? Wow! Bagay sa shirt mo. That's the color of bravery.
Color rin yan for love.
Thank you, Doc. Thank you, Nay.
Dahil ako po ay mahal ninyo, nagpabakuna na ako.
Eh, mga bata, magpabakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP, the Communication Public Service Announcement. Just one of the many creative outputs of the webinar team to push for COVID-19 vaccination. So please share this video clip in all your social media accounts. Stay safe and stay well. Magpasama na po sa Bakuna Center. Okay, first question from Dr. Susie.
Okay, thank you. First, thank you very much, Dr. Andrew and Dr. K. I mean, wonderful presentations. I think really went straight to the point, described in very good detail what we needed to know. And as you could see, there were all these hearts coming out on the screen. I think our audience is comprised of frontliners all over the country and in other parts of the world. And I think it's great to hear about the training. Okay, so this is my question. Okay, so um, the decision to go home. Okay, that's the point. I think where where you need to kind of understand the family a little bit. And kasi Andrew, you talked about the autonomy of the patient. What does the patient want? And all of that. So can you share a little bit more with us what you notice about Filipino families in terms of making that decision? Kasi once the decision is made, tuloy-tuloy na yun di ba? Pero what do you notice about the dynamics of the family? Kasi minsan, I don't know with you, Raymond, no? Kasi kung magkakapatid, ano ba yun? Yung pinakamatanda weighs in, or is it the spouse, or what have you noticed? So this is a very qualitative question. What have you noticed about Filipino families when it comes to making that decision? Andrew, ikaw muna.
Since you've mentioned, ma'am, yung panganay, actually, ang sagot iba-iba sila. Pero to the context of the panganay, ang isip ko dyan, sino yung nagsusupport dun sa family?
Ayun.
Whether
Okay.
it's here or abroad, yun
Yeah.
yung nasusunod.
I see.
But it has changed a lot. Siguro kasi bumababa, parang yung generation natin nag-iiba na. Siguro yung mga older ones, sometimes they leave it to their kids to decide whether uuwi sila or. Pero yung mga ngayon, ma'am, yung mga 50s, sila na yung nag-decide. Na gusto ko nang, ang magiging problem na lang is kung hindi kaya talaga gamutin dun sa house. Let's say, maliit yung house, hindi kaya ng bed, yun na lang yung nagiging problem. Pero in terms of decision, the older ones, kids. Pero yung ngayon, sila na. Sila na yung nag-decide.
Oo. Okay, how about you?
Yeah, ang ganda nung tanong mo, Dr. Susie. Ang na-observe ko, three things. First is, they have this, if kaya ko ba siyang alagaan sa bahay, no? The capacity to take care of the patients at home. And yun yung nagiging clincher nila. Pangalawa, it's talking about finances. Sometimes, paulit-ulit na yung nangyayari in the hospital and there's no endpoint already. That makes them kind of decide that maybe home care is best for us. And we need to really talk to them about anticipatory care. Kasi yung fear nila, kaya ko bang alagaan? Pero what will happen at home? So you give them a clear picture of what to expect. Very honest. And sometimes that decision to go home outweighs, their stay in the hospital or in other facilities. So ito yung kind of thinking that I see sa mga families who decide home care. Yan.
Okay. So yeah, thank you so much. I mean, it's very important to see that context, di ba? Kasi as you have been explaining, it's not just the patient, but it's also the family and resources and many things, no? Okay, so the other thing I wanted to ask you was, I'm glad you brought up the issue of burnout of caregivers, no? Kasi yan din yung nakakaligtaan na okay, nasa bahay nga, and it's very demanding also, di ba? So I wanted to ask, because for our audience who are mainly frontliners, what would you say would be early signs of burnout? Kasi caregivers may not notice it. I've seen this even in my own family, that they don't. Some of us are geared towards taking care of the self really well, but there are some who really, I don't know what it is, parang nag-over, parang they go overboard, no? So, yung kwento mo, Andrew, na mas maganda pa yung itsura ng pasyente kaysa caregiver. I mean, so I think it's helpful for us to kind of communicate to caregivers, like what would be an early sign na medyo dapat magpahinga muna. Hindi yung pagpagod na pagod ka na, bumabagsak ka na, di ba? Umakit na yung BP mo, doon ka na magpahinga. So what is your advice on that end in terms of early signs of possible burnout? Hindi pa nagba-burnout. Sige, Andrew, ikaw muna.
Yun pong mas bata yung mauuna. Joke lang po. Actually, ma'am, meron pong tool na ginagamit to determine if the patient has caregiver fatigue. So, meron pong mga signs, meron physical exhaustion, emotional exhaustion, meron pong neglecting ng personal needs, hindi na nagsusuklay. Tapos yung pinaka talagang clincher niyan, pag sinabi na ng pasyenteng pagod na ako. Minsan maririnig mo sila pagod na ako. Pag sinabi nila yun na yun. Yun na yung start talaga. That's why pag sinabi nilang nahihirapan na sila, hindi na sila nakakatulog, yan. So kailangan mo nang humanap ng ibang caregiver. Kailangan i-adjust mo na yung issue.
Or take a break. Take a break. Yeah, Kay, how about you?
Yeah. Taking off from what Dr. Ang said, I'm looking at physical signs from the patient themselves, no? Minsan, makikita mo magsa-start ang mga bed sore na dating wala. You know, these things na parang kasi we do have a constant communication with our patients. And suddenly, may mga biglang mag-i-inform that may konting hirap huminga, medyo nagkaroon pa ng aspiration, so those things na dapat these are part already of the caregiving that you've taught them, pero nangyayari siya. We cannot really solely blame because of caregiver fatigue, but we cannot really put that out as well, Dr. Susie, in the equation, no? So pag may mga ganon sa physical, and then even talking to the caregiver as well, there's no more parang it becomes like robotic already. So baka there's something wrong here, no? Just to make kwento lang na may mga ganito na hindi na ganun sila as much as they are updating you, nababawasan na, no? So maybe there's something wrong, and we think we really need to, mag-ano muna, respite care, that's what we call. Mag-break ka muna. You're still there coordinating with your loved ones, but not really bedside. Iba muna ang mag-care bedside, no? Kasi mahirap yon, no? Pagka may nangyari dun sa patient at home and they're not yet ready, mas mahirap habulin.
Hindi, tsaka meron talagang nangyayaring ganyan, di ba? Nag-aspirate, di ba? Nagbe-bed sore. I mean,
Ang dami, ma.
It really happens, no? So, okay, I think that those are really very concrete things to watch out for, so that you just have parang an alarm system ba in your head. Raymond, may questions ka?
We have a few, Dr. Susie,
Go
here.
ahead, take it away.
Okay, so we'll start off from Dr. Joseph Tortona. We'll put it to Dr. K. Garcia. The minimum educational attainment to be considered fit as palliative caregiver at the home.
Nako, sabi ko nga, anybody can actually give this service. Actually, it is a skill, yes, kasi at home level, it's the family who is there. And even kung may mga contraptions, maybe a midwife, a nurse, or a caregiver can help. It depends on what kind of patient. Kung maraming contraptions, of course, baka hindi kaya ng family ito. So the minimum, at least someone who is knowledgeable in administering IV, subcutaneous medications, this is the nurse level, okay? But if caregiver lang, yung mga bedside, a knowledgeable family member, competent enough, and that can report to you, that's okay. As long as naibibigay mo yung serbisyo na iyon. Okay, over.
Thank you, Dr. K. Next question will be for Dr. Andrew. Coming in from Miss Zenny Sardido. 2 questions o 2-in-1 na po ito, Dr. Andrew. Are all home-based death provided with death certificates indicating the medical cause? And do you coordinate with a chaplain for regular visits to home care patients?
To answer the first question, Doc Raymond,
Yes po. Lahat po ba nabibigyan ng pag namatay po sa bahay, lahat po ba sila nabibigyan ng medical certificate, death certificate na may medical cause? Opo.
the answer is yes, no? Kasi it's a requirement of our government that we fill in the death certificate form. So, kailangan nila i-coordinate sa barangay. Tapos, kung pupunta na po sila sa funeral service, yun ang talagang i-require ng funeral service para ma-facilitate po yung paglibing ng patient. So, death certificate is a requirement. Just like a birth certificate. So, hindi pwedeng wala.
Ayan. And then sa spiritual aspect naman, Dr. Andrew, the coordination with the chaplain for regular visits to home care patients. What is your experience with regards to that?
Sa hospital, sir, automatic siya. Walang problema. Pero ngayon lang ako nag-open up, parang hindi namin yun ginagawa sa community or kung dun sa death at the home. Para kasing baka pwede yan tignan ng pagtuunan ng pansin. So, parang i-involve yung community chaplain kapag ka nangyari siya, pwede silang mag-coordinate for the visit. But this is an eye-opener for me kasi yan yung nakakaligtaan ko. Kasi kadalasan po kasi hindi masyadong matagal naming nakakasama yung pasyente, di ba? Pag na-visit mo, after 2 days, expire na sila. Pero for the long ones, I think maganda siyang gawing project. Yun yung pina-project ng hospice ngayon is the community involvement. Sana may nurse, pag-uwi, midwife. So kasama na din siguro yung chaplain dyan. So I think Kay has something to say.
Oo. Yeah, i-add ko lang. Sometimes, Dr. Raymond and Dr. Susie, it comes from the family. Kasi spiritual here, lalo na sa sitwasyon ngayon, it gives them the strength, that coping, to go through the period of their loved ones. So kahit maganda yung pag-manage mo sa physical part, even the communication, the counseling, ang spirituality is something that we really need to look into. So although hindi siya automatic like what Dr. Ang was saying, we still inform the family that if they're okay with it, they can have a visit with their chaplain, not because yung aspect na dying to anoint, but the mere aspect that the priest is there or whoever their spiritual advisor is, it gives still them that hope. So hindi natin inaalis yun sa kanila, and they call ang kanilang whoever they would want to visit. Over.
Okay.
Yeah. Raymond, do you have a question pa there? I have one here, but then I think we have to start wrapping up. If you have one question, you can go ahead. Meron ka pa?
The question would be, I think more ministerial, but not in the sense na sila yon. Kailangan daw po bang i-inform si barangay kapag may death sa bahay? Or yes, and is it required? Do the barangay officials need to present it as part of their records? So, paano po ba yun, Dr. Andrew?
Doc Raymond, yes yung sagot. Kasi ni-require din ng funeral services na merong certificate ng barangay. Na lalo na nung COVID, di ba? Kailangan non-COVID So parang from then, nag-spring on na nire-record din nila. So kasama yun dun sa mga requirements for a death certificate.
Okay, last question.
Yes, ma'am.
Which I think I want to field because it's very interesting question. What is your experience on, kasi pag elderly patients, diba, who have, let us say, chronic illness like cancer, plus dementia, Alzheimer's. Do we have the capacity to teach or train caregivers to manage that? Doc Andrew, ka muna.
Medyo hindi ko nakuha yung question.
So what if the patient also has dementia or Alzheimer's? Do we have a way of preparing caregivers to manage that?
I think it's still the same care. Ang kailangan mo lang po dyan talaga yung magdedesisyon kung what are the goals for this patient. Kasi yung caregivers po, they will just follow what the goals are. Ganun pa rin naman siya eh. Optimum comfort for the patient. Mas extra lang kasi since the patient has, kung talagang mag-full-blown dementia siya, kung mananakit siya. So iba yung symptoms na i-manage mo, iba yung mga medications. Pero yung kailangan yung goal, yung importante. So that probably would come from the husband or the wife, kung sino man yung may dementia. Kung wala sila, I guess it will come from the children.
Yeah.
Mas madami
Dr.
lang
K.
siguro pampakalma.
Thank you. Dr. K.
Yeah, I agree with Dr. Ang. Hindi siya nagkakaiba, Dr. Susie. Medyo titignan mo lang siguro yung mga red flags here kasi autonomy is definitely an issue. So decision making will really boil down to the family. And yung capacity also to take care, no? Lalo na kung sino ba yung magkakasama dito sa bahay. So the kind of service that will be provided to an elderly with dementia and with cancer, I think it will still be the same. It depends on the situation niya ngayon. Symptom control, pain control is there. If we need to give medications to calm this patient down, to help her sleep. So talagang checklist po yan. So mas maraming diagnosis, mas complicated. But kung meron organized way, maayos din po yan.
Okay.
Over.
Thank you very much. I wish we could go on and on, but we are now pressed for time. And Raymond, you wanna go to our fun quiz?
We'll go to our fun quiz po. Yes, thank you so much. Can we have it on the screen slide though? Yes, and Zoom po. These two questions, tigisa po sila ni Dr. K for our first question. This will be for Dr. K and then second, Dr. Ang. First question, can we have also yung nasa slide po, no? Be shown on the screen. Number 1, what types of patients may receive hospice or palliative care? What's the answer, Dr. K?
Yes, so all of the above. Hindi ko nakikita yung ano, no?
Wala po sa
Yung biglang
slide pero
nawala sa
nandito po
screen.
sa may Zoom. Opo, yes po.
Oo,
Ang
but
choices
it's
po ay
actually,
cancer patients, terminally ill patients,
yes.
end-stage renal disease, stroke, and then all of the above.
Yes, all of the above talaga po yan. Non-communicable disease, cancer. Ang gusto kong ipasok dyan, not only for adults po ito, no? But even for our pediatric patients, yung mga bata, no? So, it doesn't have to be terminally ill ka lang that you will receive this service. Even at the early part of the diagnosis of a life-sustaining treatment, palliative care can already be provided, probably for counseling, for coordination of care. It depends on what is the need of our patient and their family. Thank you.
Okay, thank you, Dr. K. For Dr. Ang, second question, what types of treatment can palliative or hospice care patients receive, sir? Nakamute ka, sir.
Sir Raymond, Dr. Raymond, is all of the above. So lahat ng nakalista po dun sa choices, ginagawa po yan na palliative and hospice care.
Okay. Thank you so much, Dr. Andrew. So again, maraming salamat po. No? We'll also be asking our speakers to really work on, maybe just take 1 minute po of their time to come up with their parting messages, kung ano po yung what they want the audience to take away from the webinar po. No? As we are doing that, we'll be showing po what we showed earlier, ang ating panel discussion poll, which is the evaluation poll po natin. These are 5 questions, 4-point Likert scale, and we'll go through the list po. Number 1, the panelists demonstrated thorough knowledge of the topic. So strongly agree, disagree, or strongly disagree po. Number 2, the panelists were well prepared and organized. Number 3, panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So again, we encourage everyone to put in their answers po dito sa evaluation poll dahil wala na po kaming hiwalay na sinesend out as we move to the final messages from our speakers. Dr. Susie.
Okay, thank you very much, Raymond, and to everyone for participating in the fun quiz. We hope you learned and will take away these key messages. So let's go to Dr. K. Garcia, please. Kay, go ahead.
So siguro ang final message ko lang is that there's really a need not only for quantity but quality palliative care. So our goal is to really enhance capacitation not only by the doctors but all those who are compassionate enough to provide this service, even the family. Sabi ko nga, in hospice and palliative care, we do not add day to life but add life to the days that are remaining for our patients and their loved ones. So, yun lang siguro po ang aking parting
Thank you.
message.
Thank you. Beautifully said. Dr. Andrew Ang.
Ay, thank you, Dr. Susie.
Mm-mm.
4 bullets lang po sa akin. So yung una, sabi, no one gets out of this life alive. We're all slowly dying. So palliative care is not about giving up. Kasi yan po yung usual eh. Pag palliative care na ba, wala nang gagawin, papabayaan na lang ba siya? So hindi. So palliative care is actually a collection of medical interventions that make illness, the serious ones, and the process of dying less excruciating. And the patient's priority and the patient's preference as priority. So how can we be against palliative care? So that's it po. That's my last say.
Thank you very much. And on behalf of the whole team, we'd like to thank both of you, Kay and Andrew, for the time, the effort that you went into preparing excellent presentations and sharing your insights. So Raymond, do we want to call on our speaker for synthesis, or do you want to do the results of the survey?
We'll do lang po, maybe kung hindi pa po nakasagot lahat, we'll do just interim results because I'm seeing just 59%, less than 60% ang sumagot po. No? Mataas po. I think one of the highest, between 96 to 100% ang score po no ng ating mga speakers. So maraming salamat po to the Department of Family and Community Medicine at the UP Philippine General Hospital, as well as yung pong ating Philippine Society na kung saan po immediate past president si Dr. K. Let me just get this straight po no. Philippine Society of Hospice and Palliative Medicine. Yan po. Okay. Maraming salamat po. And to proceed po, very just a little bit unorthodox kasi sanay po tayo, si Dr. Stella ang nandito. But kilala niyo po siya. Siya po ang magdi-deliver ng ating synthesis and closing remarks. None other than the Chief of the Division of Trophoblastic Diseases at the Department of OBGYN at the Philippine General Hospital, Dr. Agnes Soriano Estrella po.
Good afternoon to everyone. So I am tasked to provide a synthesis or a summary of everything that was discussed. So first of all, I would like to congratulate Dr. Ang and Dr. Garcia for a very, very good discussion. So Dr. Ang primarily differentiated between palliative medicine and hospice care. So palliative medicine is a specialized medical care available to patients and families dealing with serious diseases. So the primary focus would be relief of symptoms, pains, and stresses with the goal of improving the quality of life of the patient. On the other hand, hospice care is basically the same as palliative care, except that hospice is given when treatment is no longer desired or beneficial to the patient, meaning to say that the goal is to continue care and provide comfort to patients who are already terminally ill, meaning to say they have less than 6 months to live. Both palliative and hospice care can be given at home, in the hospital, or in dedicated facilities. Now, later on, Dr. Ang focused on home hospice care, the emphasis of which is to provide comfort and quality of life to patients. We need to provide support not only to the patient, but more importantly to the family or to the caregivers as well, while maintaining respect to the patient's wishes and autonomy. So what are the important aspects in home hospice care? We have to emphasize the role of family members and caregivers. We have to ensure the importance of communication and healthcare professionals. And they mentioned that there has to be at least twice a month of visit by the healthcare professionals to make sure that everything is in order. And there should be a balance of responsibilities and self-care for the caregivers. There are a lot of benefits for home hospice care. Primarily, it would save money. The patients are in the comfort of their home, and there will be patient autonomy, which is respected. So at the end, Dr. Ang shared the services delivered by the Division of Supportive Hospice and Palliative Care of the Department of Family Medicine and how they go about transitioning patients from hospital to home care. And this includes even the process of bereavement. And of course, he shared with us actual patients so that we have a concrete view of what they actually do. Then Dr. Kay Garcia shared with us the Philippine experience in hospice and palliative care. So apparently it started way back in the 1980s, but we have gone a long way. We now have subspecialty trainings. We have a society. And in 2020, we even have the National Palliative and Hospice Care Program. We have laws that support palliative and hospice care. We have the publication of the Manual of Operations, and there are current education and training programs held in cooperation with the DOH. So this has been a very interesting topic. I hope that everybody learned. I actually learned a lot, as doctors, practitioners. Sometimes we take care of patients. We just discharge them. No, even if we know that they are critically ill, terminally ill, we discharge them without really taking care or ensuring continuation of care at home. So we have to remember that taking care of terminally ill or critically ill patients are actually difficult. While we want to take care of patients, we also have to take care of their caregivers. So I hope that everybody learned a lot, and I hope that I did justice to Ma'am Stella. Thank you.
Oh, thank you so much, Agnes. Ang ganda naman ng summary mo. I loved it. It was great. And I like your sharing that sometimes we tend to forget these things, but yun na nga, parang dying is part of life, no? And so I like what Kay said. Now we're not adding days to life, but what is it? We're not adding days to life.
Days to life,
Adding day
but
to
life
life.
to days.
Life to
Yes.
Galing! Ganda-ganda ng webinar natin. Okay, so for next week, we have, am I right, Raymond? We have Sibol.
We have Sibol, yes po.
So we have
Their
this group.
initiatives,
Yes,
their innovations, yes po.
Okay, so you made, for those of you who were with us from the get-go, right? There's this group in UP that works on innovations in technology and in yung may mga inventions sila, yung gagaling nila, no? So we're going to have them again. And don't miss it on Friday. It will be very, very interesting. Are we going to have Edward Wang?
Yes,
Okay,
definitely.
so we're going to have Dr. Edward Wang and his team who are inventing all these things so that we don't have to import, we don't have to import technology from abroad. So join us next week as we talk about those innovations. Raymond, over to you.
Thank you so much, Dr. Susie. And thank you again to our citizens and closing remarks speaker, Dr. Agnes Soriano Estrella. But before we conclude our program, we'd like to remind everyone that all Stop COVID Deaths webinars are archived for viewing at the TVUP YouTube channel. You just go to your YouTube app and search for TVUP PH. Click on the live tab and you'll be able to see all of those. Doon din po sa may shorts version or shorts tab po nung YouTube channel po ng TVUP PH. You'll be able to see all of our what we call SCD shorts, very, very short and consumable videos that we have prepared for you to be able to gain nuggets of wisdom from each of our webinars. So for those naman to sa browser, you just type in www.youtube.com/TVUPPH for you to be able to go to the YouTube channel of TVUP. Okay, so this formally closes po our webinar for the week. Magkita-kita po tayo again next Friday from 12 noon to 2 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, and see you online.